Good evening, everyone, and a very warm greetings from American College of Physicians India chapter. Today is a very special day because it is not just one of another episode of ACP India case file. Today is Internal Medicine Day also, and I would like to welcome our Governor Dr. Anuj Maheshwari sir to say a few words about this very important occasion in the life of a physician because I think we celebrate ourselves today and Dr. Preeti, who is going to speak on a very important case. So first, Dr. Anuj sir, it's up to you.
You. I think introduction has been given multiple times. It is not really required to be given again and again. Thank you very much, Amit. And I welcome all of you, all members of the ACP as well as non-members, those who are attending this program. My greetings from ACP India chapter as well as my best wishes on Internal Medicine Day to each and everyone who is on this platform. So today's day, 28th October, is very much auspicious that we are celebrating the Internal Medicine Day. And on this day, we have decided to celebrate with another episodes of the ECP case file in which our ECP case in charge, Dr. Preeti Dohar, would be presenting a case by herself. And this is also a very great opportunity as well as a great thing, what we call it, that a person leading from the front. So this is a thing. I am really proud of her that we are getting a person who is really ready to lead from the front. If nobody is there to present the case, she is ready to present from herself. So I welcome you, Preeti, and I appreciate your effort. And I'm really grateful that despite a lot of problems for today's program, lot of hiccups, you could be able to make it success. And today we are meeting and we are having this program. So a lot of congratulations to you. And Amit is as always is a very much inspiring and not only for PT, many a times to me also, as well as he inspires many of the members of ACP India chapter. So because of his continuous persuasion, we could be able to make this episode on this Internal Medicine Day. So I welcome and I congratulate all the physicians of India chapter on this Internal Medicine Day. Over to Preeti, over to Amit and Preeti to start the program as per the decided.
Yes. Thank you, sir, for your kind words. And it is really a privilege to introduce Dr. Preeti because now she is also an advisory council member of ACP India chapter and she is leading the advisory council for the early career physicians. And Dr. Preeti is a very experienced doctor and she is currently the head of the department at AIIMS Bathinda. And she has she has number of academic credentials. I think all of them are listed here, and you can see a lot of these credentials to her name. Welcome, Dr. Preeti. And now I think Dr. Anuj sir pointed it very rightly that you are leading from the front because I never presented a case during my ECB case files. So certainly now I will do during your tenure. I will certainly.
You are decided for the next time now.
Right, sir.
Next episode would be by Dr. Amit Gupta.
So, Dr. Preeti, now it's over to you, and please proceed with your case presentation.
Good evening, everyone. I thank Dr. Anuj Maheshwari sir, Dr. Amit Gupta sir, and all the participants for sparing the valuable time for being part of today's ACP case files on occasion of Internal Medicine Day. So today I'll be talking on a case, Hashimoto encephalitis versus, I'll be sharing the slides. Hashimoto encephalitis versus catatonia, a diagnostic dilemma.
Ma'am, just click on your screen once and then, yeah.
So I'll be presenting a case on Hashimoto's encephalopathy versus catatonia, a diagnostic dilemma. Hashimoto's encephalopathy rare, life-threatening disease entity. It presents with varied clinical manifestations like psychiatric as well as neurological diseases. And it poses a challenging clinical scenario for physicians, leading to delay in diagnosis and management. Incidence is underestimated and with a very low overall awareness about the disease. Hashimoto encephalitis presents a very difficult diagnosis to us because it mimics a large number of diseases like meningoencephalitis, psychiatric disorders such as psychosis, depression, and catatonia, degenerative disorders like Alzheimer's disease, Creutzfeldt-Jakob disease, paraneoplastic, non-paraneoplastic limbic encephalitis. Clinical features can be varied, with a presentation can be from any of the multiple organ systems like seizures, confusion, hallucinations, dementia, psychosis, ataxia. Then patient can present with myoclonus or stroke-like episodes, abnormal gait and abnormal movement disorders, or can even present to us with coma. Catatonia as a presenting manifestation of Hashimoto's encephalopathy is unusual. And I am presenting a case of 44 years old female with history of episodes of depression for the last 4 years on irregular medication from different clinicians. The patient presented to our outpatient department OPD and was admitted for further evaluation. She complained of stiffness of bilateral upper and lower limbs for 5 to 6 months, which was insidious in onset and intermittent in nature. It was associated with decreased activity, decreased oral intake, decreased interaction levels, posturing, and presence of involuntary movements in bilateral upper and lower limbs for the past 1 month. There was no history of fever associated with the episodes. There was no family history and no associated comorbidities. On examination, she was calm, conscious, cooperative, oriented to time, place, and person, and the general physical examination showed pallor and blood pressure of 122 by 84 millimeter of mercury. Pulse rate was 90 per minute, saturation 99% on room air, and she was afebrile. On neurological examination, the muscle bulk was decreased in bilateral upper limb and lower limb. Limb rigidity with muscle tone was increased in bilateral upper limb and lower limb. Grade 4 power in bilateral upper limb and lower limb. The tendon reflexes were very brisk, 3+ in bilateral upper limb and lower limb. Plantars were mute with resting and action tremors. So we did the normal routine investigations, hemogram, renal and liver function test, ESR, C-reactive protein, serum ammonia, blood gas analysis, autoimmune and infectious markers were done, cerebrospinal fluid CSF study of proteins, cells, glucose for bacteria, and viral infections were done. EEG was performed. All of these investigations were found to be within the normal limit. Magnetic resonance imaging MRI of the brain revealed no intracranial abnormality. MR Parkinsonism index was 11.3, which was within the normal limits. Serum creatinine kinase 27.1, CK-MB was 15.3, serum LDH 167.2 were within the normal limits. Serum for anti-NMDAR, anti-VGKC, and anti-LG11 autoantibodies was tested, and it was found to be negative. So during the hospital course, after 2 days after hospital admission, the patient was conscious but became disoriented to time, place, and person. She stopped responding to verbal commands and superficial pain but responded to deep pain. Furthermore, she kept staring at a place for 2 to 3 minutes and became mute, and posturing was present. Fundus examination was performed at that time for any raised intracranial tension, but was found to be within normal limits. And urgent cranial computed tomography was performed, which also came out negative for any other pathology. So a possibility of acute catatonia was kept, and lorazepam challenge test was performed 2 milligram IV lorazepam stat was given very slowly. Initially, there was a fall in BP and she was started on injection lorazepam for her symptoms. But there was no marked decrease in rigidity and no improvement in the symptoms or in the interaction level. Injection lorazepam was stopped. She developed jaw rigidity with non-closure of the mouth and increased oral secretions. There was fall in her temperature recordings from 98 degrees Fahrenheit to 95 degrees Fahrenheit. ABG was performed to rule out any other cause of drowsiness, such as carbon dioxide retention, but that was found to be within the normal limits. So we evaluated her for other autoimmune causes for her clinical presentation, especially for myxedema coma or Hashimoto's thyroiditis. The thyroid profile was done, which showed a normal T3 and T4 levels, but the TSH levels were raised, and then the anti-TPO antibodies were tested, which were again found to be raised. So keeping in view the differentials of Hashimoto encephalopathy, she was given injection hydrocortisone 100 milligram IV stat followed by 50 milligram TDS. And she was started on tablet L-thyroxine 500 microgram per oral, which was followed by 100 microgram per oral OD. Steroids were tapered off, followed by oral steroids, and the patient showed significant improvement in the general condition. Responded to verbal commands, started talking, and showed a drastic decrease in the muscle rigidity. On follow-up, we found that the patient recovered symptomatically and started functioning well. So, now coming to the discussion of this case, catatonia versus Hashimoto encephalopathy. Malignant catatonia, as we all know, it is a life-threatening condition. It also presents with similar clinical signs and symptoms, presents with fever, rigidity, altered sensorium, posturing, mutism, and autonomic instability. Common symptoms like immobility, stupor, mutism, posturing, staring, echolalia, and echopraxia are present. Lab findings in malignant catatonia suggest leukocytosis and raised creatine kinase. Diagnosis is by the lorazepam challenge test, and the treatment is benzodiazepines, and in severe cases, electroconvulsive therapy can also be given. We have seen in malignant catatonia, Hashimoto encephalopathy also presents with similar symptoms, but it is also known as steroid responsive encephalopathy. It is a rare disease entity associated with autoimmune thyroiditis, more common in females as compared to males. There is no specific age predilection. Pathological origin is uncertain, but autoimmune vasculitis can be suggested as one of the pathogenesis. Presentation can be varied: acute cerebrovascular events or a progressive neurological decline with tonic-clonic seizures, myoclonus, tremors, hallucinations, and psychosis, fluctuating in course, or it can be progressive. Investigations which are very important in this is high titers of anti-thyroid antibodies. Now the interesting thing is that the thyroid status can also vary. It can present as subclinical hypothyroidism in 23 to 35% of cases, hypothyroidism in 17 to 20%, hyperthyroidism in 7%, and it can even present as a euthyroid status in 18 to 45%, therefore making the diagnosis of this condition all the more difficult. Treatment: it responds very well to steroids. Immunomodulation such as intravenous immune globulin and plasma exchange may also be effective. The course of total duration of steroids to be given is not very well studied, but it can be tapered off as per the clinician course of the patient. Prevalence of Hashimoto's encephalopathy is 2.1 per lakh people. It is also known as steroid responsive encephalopathy associated with autoimmune thyroiditis, or a new terminology has also been used for it, that is non-vasculitis autoimmune inflammatory meningoencephalitis. And the main diagnostic criteria to be included is the steroid responsiveness of the disease. Hashimoto encephalopathy was first described by Lord Bryan et al. In 1966, who summarized the case as stuttering brain disorder of an unusual kind with concurrent rise in the level of thyroid antibodies, and concluded, showing remarkable foresight, antibody studies in future cases of unexplained encephalopathy should show whether we have described a syndrome or a coincidence. Hashimoto encephalopathy consists of two subtypes. First is an insidious, recurrent vasculitis type, demonstrating stroke-like attacks concomitant with impairment of consciousness. Second is a progressive and the more commonly seen form of encephalopathy, which presents itself with confusion, psychosis, somnolence, and coma. The mechanism of action: result of edema and reduction in the vasculature due to autoimmune mediated central nervous system vasculitis, together with impairment of the microvascular structure. Or the second hypothesis that has been proposed is formation of antineural antibodies and cross reaction due to a common antigen of both the thyroid gland and the brain. Direct toxic effect of thyrotropin releasing hormone has been postulated, and autoantibody or immune complex deposition leading to injury of microvasculature. The diagnosis is difficult because of varied clinical presentations resembling common medical conditions such as septic encephalopathy, renal and liver failure, malignancies, and vascular diseases. So it must be considered in cases of investigation negative encephalopathies. Our patient had a previous episode of depression and presented with rigidity, mutism, posturing, altered sensorium that can be explained by catatonia. However, there was no improvement with antipsychotic medications, which is contrary to the improvement usually seen in catatonia patients. Patients with Hashimoto encephalopathy can have a rare presentation very similar to that of catatonia, which is steroid responsive as seen in our patient who showed significant improvement in the neurological status with steroids. Moreover, our patient had an associated hypothyroid status for which he was started on thyroxine. So what is the take-home message? Being a diagnosis of exclusion, one must be aware of Hashimoto encephalitis while treating a patient of hypothyroidism, along with neurological features in the background of high anti-TPO titers. This warrants use of steroids, which shows dramatic improvement in the condition of the patient. Thank you.
Thank you, Dr. Preeti, for a very excellent presentation on this important topic. I would like to mention that hypothyroidism is a very, very common medical disorder and we frequently encounter in our clinic. And it is also a very common phenomenon that many of these patients, they have elevated anti-TPO antibodies are there. So this is not something which is, we see both these together very commonly. But and many of the times, these patients also have some symptoms which you can think of like depression, anxiety. They may also be having some other symptoms like irritability and like mutism and all these can also happen. So Dr. Preeti, I would like to ask you that at what point of time actually you suspected that this can be, this is not a classical case of catatonia, and how did you correlate it with hypothyroidism? And second, one more thing which I would like to ask you that, is there any correlation between the antibody titer and the risk of developing Hashimoto's encephalopathy?
Sir, we had given the lorazepam challenge test to this patient, suspecting it to be catatonia only because she was previously being treated since 4 years on antipsychotic medications from various clinicians. And so we suspected catatonia, then we gave her the lorazepam challenge test, and at the time, there was no improvement in the symptoms, which is very contradictory to that in catatonia. So then we thought of doing these autoimmune markers, and out of which TPO antibodies and antithyroglobulin have a main role in this condition. And so there is no clear indications of the level of titer that should be present. It is basically a disease of exclusion. Encephalopathy of excluding other disorders. So if the NT-TPO titers are raised, then we can suspect Hashimoto encephalopathy, but there are no clear diagnostic criteria and the level of titers of NT-TPO antibodies.
Thank you for that answer. Sir, Anuj sir, would you like to ask anything?
Yes,
or
I
make a
think
comment on this?
this encephalopathy is not very commonly seen with the thyroiditis, and especially in the setting of the autoimmune phenomena of the thyroiditis when we are coming across with Hashimoto. We have seen that situation where thyroid crisis is there and patients are presenting with behaving like encephalopathy or sometimes unconsciousness. But it is really a very rare situation where you could see that Hashimoto is presenting with the encephalopathy, and it is a very good message for the attendees that whenever they are coming across with the encephalopathy, they should also explore the thyroiditis kind of the situation, especially look forward and keep in mind about the Hashimoto.
Right.
So really a
Dr.
very good
Dr. Preeti, I would also like to ask you, you mentioned about the lorazepam challenge test. So I don't think we do it very often and very commonly. So it would be important if you can explain that how this test is done and what exactly are the endpoints you are looking for. What is the dose of lorazepam you give in these patients?
So 2 milligram IV lorazepam has to be given stat. And then we have to see for improvement in the posturing, improvement in the rigidity, and improvement in the reflexes, and overall improvement in the symptoms. If it is a patient of catatonia, it will respond to lorazepam. Benzodiazepines are also the second mode of treatment, but it will respond to lorazepam. Catatonia usually responds, but in cases where there is no improvement with this lorazepam, then we should think of other differential diagnosis.
Did your patient was also having the some schizophrenia kind of the picture or this kind of the symptoms?
So she had more of depression and anxiety, irritability, but it has been mentioned in the literature that Hashimoto encephalopathy patients can also present as with schizophrenia-like symptoms.
Yeah, so she was not having that kind of diagnosis.
Depression. She was on treatment for depression for so much.
Depression. She was already taking treatment for the depression,
Depression
but psychiatrist has not reached to the conclusion that she may be having the schizophrenia.
Yes, sir. And because there was no improvement in the depression or symptoms with any of the antipsychotic medications.
Okay.
And now she's coming to our OPD for follow-up, and she's leading a perfectly normal life.
And without any antipsychotic medication.
Yes, sir. She's only on steroids. There is marked improvement in the symptoms.
Without any antipsychotic medication, now she is leading normal life.
Normal life and doing all her household work. She's still in a follow-up in our OPD.
This is again a very important message to all our attendees that many times people keeps on doing the psychiatric treatment without going into the details of the possible causes. And if we can really explore the possible causes, we can avoid a long-lasting, and many people may be having the lifelong treatment for the depression and schizophrenia kind of the situation. So it's better to explore all possible causes, and one in the Hashimoto's thyroiditis to list.
I think, sir, if that decision would not have been made in this case, she might have been referred to the other modality of treatment like ECT and all, which Dr. Preeti mentioned that these are the standard way of managing catatonia and all. So, Dr. Preeti, I would just like to ask you two quick questions before we proceed to the next part of the program. One is that for how long would you like to continue the steroid therapy? What are the indications that for how long steroid should be continued? And if you want to plan to taper off steroids anytime soon, then how you plan to monitor this patient? Are there any chances of recurrence happening in this patient? What is the life expectancy of a patient with Hashimoto encephalopathy?
So following initial treatment, the frequencies, they lapse into remission. And with a proper treatment, a person should expect a typical life expectancy. And because it is a rare disease, very low awareness, we do not have any diagnostic criteria for it. It is only a encephalopathy of exclusion. So steroids we can start, but we have to taper and monitor the steroids according to our clinical judgment. and according to the improvement in the patient. As such, there are no clinical guidelines anywhere on the dose and when to taper, how long the treatment should be given. So it is basically the clinical judgment of the physician.
Right. And as you mentioned that since it is a diagnosis of exclusion, so then what is the role of any standard test like MRI, doing EEG in these patients? So is there any specific finding which you may be able to get in these cases?
Sir, MRI is mostly normal or non-specific in these cases. Same is the case with EEG. In MRI, we can have edema, we can find edema, we can have ischemic lesions, or we can have atrophy, or we can have temporal hyperintensities. But mostly 90% of cases, MRI will be normal or show non-significant lesions. And same is the case with EEG. Mostly the EEG will be normal in this case, and sometimes it may show spikes or delta waves, or but EEG is certainly important in the prognosis and in the response to the treatment. When you have put the patient on steroid therapy, EEG abnormalities improve and rapidly with steroid treatment. And there are studies which have shown that EEG improves with steroid treatment in such cases.
Thank you, Dr. Preeti, for the case presentation again. And I think our viewers, all the early career physicians and even the advanced career physicians, now we have another terminology which we are using very commonly in the ACP. Now we have advisory council member again for the advanced career physicians also. So I think it is a good learning for each and everyone. Once again, thank you very much for setting this up. And now it's time to move to next part of our program, that is ACP case files, where we are going to ask our governor, Dr. Anuj Maheshwari, so that what is ACP exactly on this Internal Medicine Day? What is the importance of internal medicine in medical science? Why is this important to have ACP? What is the role of ACP? So I think we have so many questions, and though Anuj sir is telling us again and again, so we thought it is good to put them all together. So those who are members, they understand that what ACP stands for, and those who are not member, they are able to understand that what are the benefits of becoming ACP member, what it brings to them. So, sir, I would start by asking the first question, that what does ACP stands for? What is the importance of this international body in India, and how do you see it?
Thank you, Amit, for keeping this program and for keeping this topic especially today. And we all know that ACP is one of the largest body of the physicians across the world, which is having more than 1,61,000 members as a physician. And this body is actually has been established in 1950, and this has a mission to enhance the quality and effectiveness of healthcare by fostering excellence and professionalism in the practice. And that is I think that seems very ideal, but it is not very easy to achieve these kinds of the mission, especially in a country like India. These things becomes more difficult when we see that lot of lacunas are there at the infrastructure level. Even people are not getting appropriate treatment at the grassroots level in the remote areas of the villages. Then this mission seems a little difficult. But anything can be achieved once we start thinking to achieve it. So that's why this is a more important to start working to achieve a big mission instead of not doing anything. As an ACP, our vision always remains that members of our organization should be recognized as leader in the medicine globally, not only in their country but also across the boundaries of the country. They should be known and they should be recognized for better patient care, better advocacy, better education, and as well as they must be having a better career fulfillment, not only in their terms of earning, but also in terms of satisfaction also. And we include here not only those who are working for the general medicine, but also those who are working for the subspecialties. In India, we call them the super specialties. There's a difference in the terminology, but things is the same, like gastroenterologist, like cardiologist, like endocrinologist. For everyone, ACP is ready to work for and would ready to encourage them to move forward and getting international recognition.
Sir, it is really a proud feeling to know that what are the missions of the ACP, and actually, again, it is a matter of pride that we are all members of this prestigious body, which is one of the largest body of the physicians all across the world. So, sir, I would like to know that what exactly is the structure of ACP, how it is, how many chapters and regions are there in the ACP?
ACP is a, as I said, that it is a body of the American physicians, which has been started in 1915 with the Americans physicians, those who were working in United States of America. Later on, they decided to expand it out of the boundaries of their country, and then they started getting the chapters of the in different countries, and every country is having a chapter as of now. But there could be a possibility when numbers of members are more, then there could be more than one chapter in one country. Like United States itself is having the 85 chapters. So 85 chapters are in the United States and 14 chapters are the international chapters which are working with the ACP. And every chapter leader is called the governor, which is reporting to the ACP headquarters, which is headed by the president ACP as at the helm of ACP.
Thank you, sir. It is nice to know that. Sir, we have ACP India chapter, and you are leading as a governor of the ACP India chapter. You have seen ACP India chapter right from its inception, its development, its beginning. So, what are the purposes which ACP India chapter is serving? What at all the ACP is doing for its members?
Yeah, as I already said in the beginning, the idea behind the ACP is that to achieve the perfection and excellency in the practice of the doctor. And not only in the practice of the doctors, but also in the healthcare system of the country. They started this mission in United States, but in our country also, mission may not be very much different. We all are really looking for the better healthcare services would be provided to each and every person of our country. And how can a physician contribute in achieving that goal of the health for all? Health for all is a program of the WHO which has been accepted by our country government also. But this can only be a reality once the physicians contribute from their own side. Not only the rights of the physician, but also the duties of the physician are very much important towards achieving the goal. At the same time, what is a unique thing, what I find always and appreciating from the ACP, that ACP is not only very much caring for patient and healthcare system, delivering the good care of the patient, but also very much attentive and caring for the healthcare of the healthcare professional, healthcare of the doctors, those who are part of ACP, health of the physicians, those who are treating the patient. So this is again a very much appreciable at the point of ACP. We have not seen many organizations in the world are really looking forward for the health and well-being of their own members. They are mostly directing towards the goals or missions, whatever they have made to achieve, and they try to achieve them. They keep on trying to achieve them, but always we should remember our core who is fighting to achieve the mission. If that would not be healthy, that would not be happy, that would not be the satisfied of their working and profession, probably the achievement of the goals would not be easy for anyone.
Sir, you have rightly said that, as you know, that in the era of subspecialty or the super specialty, slowly and gradually the glamour or the attraction of the internal medicine was fading. But I found that ACP is one of the body which is actually a voice of each and everybody who is practicing internal medicine. It brings a lot of proud, and its tagline is that I am proud. So internal medicine proud. So I think it is really a very, very nice thing. And We have all seen that ACP India chapter is doing so many activities all around the year. Almost every week in your tenure, we have seen that there is some activity which is happening, whether it is online or offline, and we are taking care of you are taking care of almost each and every aspect of the care, whether it is physicians' well-being, doctors' well-being. We are talking about different issues. You have undertaken the women's health issue and so many things. So Dr. Preeti also has many questions in her mind. So I request Dr. Preeti to also.
In fact, it is not me, it is we who are
Yes.
doing that. Actually, I cannot do anything alone. I can simply doing by support of all of you who are a part of my team, those who are presently in advisory council or before the advisory council, or not only those who are in advisory council. Each and every member is contributing towards the organization. Unless it will not happen, probably we will not be able to do any good work. The only thing what you can expect from a leader that he continue inspiring to something and something to its members. And what I try to make the people always remain working awake and remain vibrant so that they may be doing something or other thing in their area or in their field or in their specialty, whatever they can do. So that I try to do. How much I am successful probably after completion of my term this will be told by you people and many other those who will be observing it throughout these years. But it should be an endeavor from any governor or leader who is heading the organization, and that I try to achieve in my capacity, whatever I am.
The one thing which has happened for sure is that now each and every physician, he or she knows about ACP. There is a American College of Physicians India chapter, and something is happening, and it itself is a very, very big achievement in a country as big as India. So many congratulations to you as well as your team as well as all the ACP
Our
members.
team,
Now,
and including you also. That
yes,
team is
sir, I am part of your
also.
team.
And in fact, you have done a lot of things for the ACP. And what I understand that in India, a lot of organizations are working for the betterment of the health of our countrymen as well as for the betterment of the doctors, and they're keeping the interest of the clinicians for various diseases. Like some organization is working for some specific disease, some organizations working for overall physicians. Multiple organizations are there, they are working for the physicians. But I know except a few of the organizations, many organizations could not reach to that number. That number our ACP has already reached as a membership. Although we are having a big challenge every year to renew the membership. Until we will not be delivering a good uh, something good to our members, it would be very difficult to convince the members for their membership renewal. So, and membership renewal, that too a very handsome price. If members are ready to pay, this can only happen once we generate some uh, enthusiasm in each and everyone to work jointly, work together for the betterment of our people. People are our countrymen as well as people are our physician friend, as well as we also try to involve other specialties, because now the time is coming when multiple specialties had to join hand together. We have seen this in the COVID. COVID was not a thing which could be handled by one specialty. Until unless the specialties will not come together, it would be very difficult in coming time to take care of the people, like gestational diabetes. We are seeing there that multiple specialties like physician, endocrinologist, as well as gynecologist, obstetrician, all have to come together. Similarly, even in diabetes, now we think that diabetes is expanding its area towards the gastroenterologist also. Earlier, endocrinologists were already the part of that, physicians were the part of that. Lot of surgeons, being a podiatrist and diabetic food management, they were the part of that. Now the gastroenterologist very soon will be the part of the management of the obesity, management of the diabetes. Bariatric surgery has already involved them for the management of the obesity. And I believe in coming times, as the NAFLD is being associated with the obesity and diabetes very frequently. Now we shall be seeing the gastroenterologist would be thinking about the managing diabetes also in some different way. And already the neurologist and many other specialty, nephrology, neurology, they have always came into the expansion of that disease. So diabetes is a disease which has involved each and every organ of the body, and this management needs a combination and association of multiple specialties at one place. So this is the thing what we really look for. And I believe that ACP should also start working in that direction, that to bring the specialties coming under one platform, under one umbrella.
Sir, many of our physicians, they would like to know that how they can become a member of ACP India chapter and what are the various levels of membership.
Yes, obviously, if a person wants to become ACP as a member, for the first time he is joining the ACP or wish to join, he has to take the membership. Membership depends upon the level of the person. If a person is a practitioner and he is building the postgraduate qualification for the management of diseases in the medicine, then he can take the routine membership of the ACP, which is called as membership. And if a person is simply MBBS or is holding degree of some other specialty but having some interest in the medicine, like a person who belongs to the pediatrics, a person who belongs to the dermatology, a person who belongs to the anesthesia, and he wants to become the member of the ACP, he can take the membership as a physician affiliate. And if a person is a resident in the growing phase, he can take the resident membership. For the student, we are also having the category of the student membership, which is free of cost. A person who is pursuing MBBS, he or she can take the membership to ACP without paying anything till his or her MBBS is going on. Even completion of the internship, we provide the free of cost, and it helps them to getting a career, getting a networking, as well as in the knowing the whereabouts out of the countries also. Not only in United States, but all those countries which are associated to the different chapters of the ACP, they all are, and those they all are ready to open the opportunities for all members of the ACP, even for the students members.
So, sir, what are the many benefits of becoming a member of ACP, and how does this ACP India chapter honor their members?
Most important, as I already told, that benefits is that you can explore the new opportunities and new avenues in the career. If a person is at the level of the student, he can think about further studies. You know that now in our country, further studies are not very easy. In our country, a person, if he has completed MBBS, then he needs to go for the post graduation and he has to clear a NEET examination, which is very much competitive. And many a times, people, those who are willing to get the post graduation, they may not be able to beat it. For them, there maybe they can explore the opportunities in other countries where it could be easy to get the postgraduate seats or postgraduate placement for them, because many countries are there in the world where they are not getting appropriate candidates for these kinds of the situation. In our country, we are overpopulated country, we are overcrowded country, we are having the a scarcity of multiple things in almost all parts of the life. We are having so many things which are really lacking and scarcity is there. But there are countries which are affluent, which are really needing more people to work for them. And but only problem is that we don't get any common platform on which we can meet those people who are needing the people, and those who are really looking for the job and looking for the postgraduate seats and looking for their more and more qualification to attain. And when these two kinds of the people come together, they actually fulfill each and each other's needs in a better way. And that the ACP is actually doing by taking them on the one platform. This is the biggest advantage. The people, those who are in the growing phase, those who are in the residency, those who are in the early career days, because early career days are again very much struggling, especially in India. Many people may be having an option to go other countries and working there, make them more qualified, getting them more training them, and then they can come back to India to serve the people of the country. So by doing so, they can get an easy way of making them some more qualified, and later on they can come back to their own country, their own people. So these are the benefits one can get in their doing it. Apart from that, once the established physician is there, like we all are like that, those who are working in their field, what are the benefits of the ACP? It gives us a networking opportunity to meet the similar level of the people of the other country. Once we do the ACP meetings in those, we meet the people, those who are having the ACP chapter in their country, like Bangladesh, like Japan, like Brazil, like UAE, and many other countries may be there who are having their chapters in their country. And they come together and we can meet them, we can find, we can explore the possibilities of inviting them in our country, and we can also be invited in their country for our specialty. And at this point of time, when we are having good practice, when we are having good recognition in the society, everybody wants to get the name and fame. And by connecting with the ACP, when you come in the club of those 161,000 physicians, you can easily get connected with each another, and it fulfills our desire to get name and fame and be satisfied with being invited as a speaker and being invited as a fellow and being invited for some oration in other countries. So these are the benefits for our kind of people, and for the senior people also. ACP has a lot of ideas and lot of things. What I understand that ACP is continuously keeping one thing or another thing for its members, may it be of the early career physician, may it be of the advanced career physician. I am really willing to start something for the advanced career physicians in India too, because in advanced career physician India there is no specific policy, there is no specific kinds of the guidelines. People get retired of their job, and after that they are thought that probably they are not of any use, and many of them keep on doing the practice. Obviously, physicians can continue their practice, but the people, those who are in other specialties like surgeons, like ops gynae, they are not having that much bright career in practicing even after the retirement. So these people can be involved somewhere to guide the other. They can be utilized for their energy to guide the juniors, those who are coming up, and those who are growing in their career, and they can help them to make the new doctors more brighter future, and they can be invited there for their sharing experiences in various meetings and conferences. And apart from that, we can also think for their health, because advanced age, once a person reaches, he needs to take care of his own health also. Many of our doctors are busy taking care of the health of others. They are not really looking for their. Through the ACP, we can find some opportunity to make some healthcare program for the advanced career members of the ACP. And we can also contact some insurance company which can provide some blanket kind of the insurance. A lot of things are there which could be planned if more and more people join hands together under one platform.
Sir, I would, you have rightly said, and recently we got a mail from the ACP that there is a career placement, online career placement counseling is happening. Whenever there is a so many online programs are happening where members from all across the world, they can join and learn and even get connected for job placement and upgrading their clinical skills. Sir, I would just like to ask you one thing. We have so many members and all. And in most of the societies, what we see is that there is members will always complain that they find it difficult, though they have taken the membership, but they are not finding any way to get engaged. And I think this is one of the very important point which you brought, that it is not just the program which we conduct, then how do you engage the members? So it would be nice if you can tell us that what are the ways a ordinary member or anyone who joins the ACP, how can he get going, how can he get engaged, and how can he approach you if he has any idea, suggestion. So it would be nice for our membership.
Yes, we are already planning this engagement activities. That's why we have started using the portal system of the ACP for reaching to each and every member. And we try to communicate each and every members at least once in a week for one reason or another reason. Sometimes by while giving the information of the posting program, sometimes communicating the newsletter to our member, sometimes communicating any other information which may be of their use, and many a times we also keeps on treating our members to the portal for various festivals, for various important days. So they can really write back on those mail, where whatever the mail we are sending to them, if anybody writes back on that mail will reach to me. So I can always see if a person writes anything, and my mails which are coming from the ACP, in which is being addressed for uh, any uh, thing like any festival congratulation or any festival uh, greetings we are giving, then we can get that. Or any information regarding any program or we are giving, a person is writing back, we can get that information and we can respond him accordingly. Apart from that, my email ID and my phone number is given on the ACP platform, ACP India chapter website, as well as the acponline.org, which is the international website on which there is an India page. They can get all information to reach me, and I am most of the time available to anyone who is calling to me or my office, or if anybody writes anything, any idea. People can also give their idea to work for the ACP. You very rightly said it is important to engage them for various ACP activities, for which we have started doing the work with you also, you know that we have expanded our ECP council. Now I am also thinking to expand these kinds of the council in other specialties, like I am also make a women council, like I'm going to make advanced career physician council. I can make on a ECP council is already working there. Many people has got elected for the advisory council. We can replace them with a new member so that many new people can get an opportunity to work for the early career physician council. Similarly, we can also think about making the councils which can work for various other parts of the healthcare. Like we can think about the people who are working in volunteerism. They are helping the patient in one way or another way. Because every patient is not a every patient is every clinician or every member of the ACP is not a member who is having the academic credential, who is having the paper writing skill. Every members may not be having the skill to become a very good speaker or orator. So many members would be very happy to help the patient continue, make some innovations in practice. They would like to have some newer innovative methods of treating the patient, and how can they make their own health also while seeing the hundreds of patients in a day. I've seen a very interesting thing in one clinician's place, where I saw that that clinician was busy from morning to evening looking over the patient, and maybe 50 to 100 patients he is seeing in a day. But what he was doing, instead of sitting at one place, he was going to the patient instead of calling the patient in his chamber. So there were 4 5 chambers were made, and he starts from the first chamber, uh, treats and greets the patient, then goes to the other chamber, greets and treats the patient, writing the prescription. If he requires any investigation, ask him to get that. And similarly, one by one. So he keeps on moving throughout the day. So this is an innovative approach for keeping yourself moving throughout the day when you are in on work. It's not required that you are sitting at one place and making yourself breathe and increasing your girth of the waist. So you need not to do that, and you can get it. So these kinds of the innovative thing can be spreaded, can be communicated to others. And somebody has done some very good experiments. And these things can only be possible once we all are meeting at one platform. We are keeping in communication. We are talking to each other for one way or another. And you are right, we are also exploring many other ways to engage more and more people, especially from those areas which are underprivileged and not so well reached as of now for the member, that like Northeast, where very rarely anybody does the program. Some other areas of the countries are there where people don't really go the program, and many physicians are not really active in the social activities and even conference and academic activities. That's our first conference I did at the Goa. Goa is a place where physicians are not in very big number, and those who are there, they are quite satisfied and engaged in the activities, whatever they are doing locally or not. They are not really connected to the national organization so well and so uh, so uh, uh, inter, uh, so interested, so much interested to get connected with the national body. So what I really did that I just got an opportunity to make them at under the one platform, and not only I could be able to make them connected with the our organization, but I could be able to start the RSSDI Goa chapter also in that meeting. Whenever what I did and Goa on the ICP platform. If you remember, we did the Society for the Study of Diabetes in India chapters meeting also, the Goa, and those meetings, the Goa chapter has been included. So these things can be done for the subspecialty. And ACP always believes in joining hands with the subspecialties and the societies of the subspecialty. And we can do and we can involve them with others. So it is not only that we are only the thing and we will be doing only on our platform. We are ready to mix with anyone. We are ready to join hands with anyone, whosoever is interested. And we are ready to work in each and every field of the medicine, whatever it may be.
Thank you, sir. I think we can take one or more question. It's already time. Dr. Preeti, would you like to ask anything from sir?
Sir, a very simple question. Whether medical students, if they want to join, whether there is a difference in the fee membership fee structure for them?
For medical students, if they are in the graduation, means if they are not completed their internship, there is no fee at all. They can join free of cost, and they can enjoy each and every feature of the ACP, including the ACP benefits, including the Dynamics, including the annals, including all other activities which are available to the ACP members free of cost, without paying even a single fee. So the rest of the members, when resident student member or postgraduate members are having little bit fee, but which is not as that much, which is for the routine members, almost 1/3 of the routine members. And routine members also in India are paying much lesser fee what is being paid by their counterparts in United States. So we are getting a lot of privileges from the ACP, and for which we can really make them benefited our country people.
Thank you, sir.
I think, sir, there are so many benefits, whether it is the journal, whether it is the Dynamed app, whether it is the access to online educational modules, CPD activities, and the opportunity to be a part of different volunteer work.
MKS app.
Yes.
For
If
the
we
student.
keep on talking, I guess we can spend another hour talking only about the ACP activities, but I think it
We
is.
can have one more. We can have one more session for that. We can have still many things to talk about the ACP benefit, and we can talk about the
Right.
chip and app. And we keep on doing such kind of the program in various intervals. Remember, few months before we have done the how can one upgrade the fellowship and what are the benefits of getting the fellowship. So similarly, we will be doing these kinds of program in future also. So I think we can conclude this. You can make it.
So I can pass it back to Dr. Preeti because now she is in charge of early career physicians. So Dr. Preeti, do the honors, please.
So it was wonderful interacting with
You
everyone.
head of the department.
So it was wonderful interacting with everyone today, and I hope for many, many, many more case files in near future. Thank you, sir.
Thank you, sir, and wishing everyone again a very, very happy Internal Medicine Day.
Thank you, everyone.